Sure. So many of you work with us, but PCH is a psychological treatment program with the emphasis on the psychological, that we use medications in psychiatry as adjunctive to lots of different therapeutic experiences, individual therapy, groups. We do lots of exercise. Aerobic exercise has been shown in research to be more effective than anti-anxiety and antidepressants with positive side effects. We do a lot of art, so we really try to focus on the whole person. And diagnostically, we use the DSM for insurance purposes because it's a necessary evil, but aside from that, we don't really use it. It's devoid of context. It places the problem in the individual, and it's as they mentioned in the film, there's very little biological basis proven for any of the so-called disorders. And so, we don't even accept the concept of mental illness as being sort of a medicalization of human experience.
Thank you so much for giving that introduction. I'm going to tell you briefly who the panelists are and let each of them share a little bit of opening thoughts. Dr. Jeff Ball is Assistant Clinical Professor at the Semel Institute for Neuroscience and Human Behavior at UCLA, and he is the CEO of Psychological Care and Healing Center. Dr. Adriana Westby-Trent is an adjunct faculty in the Marriage and Family Therapy program at Pacific Oaks College, and she's the Clinical Director of Psychological Care and Healing Center. Dr. Timothy Pylko is an adjunct clinical professor of psychiatry and behavioral sciences at USC School of Medicine, and he is the executive director of PCH Pasadena. So Jeff kind of shared some opening thoughts. Can I hear from Adriana?
Yes, thank you, Angie. Right, so one of the beautiful things about the film is that, as Jeff mentioned earlier, it mirrors the philosophy of PCH so very well. I come from, before PCH, 15 years in the Department of Mental Health, a contract agency. And so very much trained in the medical model and witnessing a lot of children in the foster care system, many of them very early on from 2 or 3, especially with severe behavioral problems, who are being medicated. And so it's just, for me, looking back just at that system, and it is that system even now, that really it's about behavioral control as opposed to really working on the social, economic, and traumatic experiences that these children are going through that are contributing to their behavior. So we're very grateful to have a film that will be out there to, share this reality.
And Dr. Pylko?
Well, I think the title is a good one. You never want, it's really the absurdity of medicating normal. Now, first of all, I don't like the term normal, because normal, in a way, who defines what's normal? I really believe in diversity of the human experience and what's adaptive, and living a meaningful and purposeful life, being adaptive to the community that you live in. So the idea of normal feels like the tyranny of the general population against individuals' need to be different. So that's my philosophical point of view. I don't believe there is such a thing as bad medication, or good or bad medication. There is good or bad psychiatrists, good or bad mental health practice. And if used appropriately, there is a place for all the medications that were mentioned in this film. The problem is there's too much bad mental health care out there, and some of it is really driven, as described by some financial interests, both from the pharmaceutical industry, who have created some very useful medications, but are focused on profit. I really recommend, if you have Hulu, watch Dope Sick, which is on Hulu right now, about the Sackler family and Purdue Pharmaceuticals, and how they have had a big responsibility in the current opioid epidemic in the United States. It's a docudrama based on a nonfiction book. It's really, really, really good. So I think we see lots of examples of really bad mental health care in this film, yourself included, and it just saddens me. But one of the things that I don't want to go on too long, but one of the things that is really difficult is the lack of the limited resources we have for mental health care in this country. I mean, what we really believe is at PCH is treating the whole person on every aspect. I always talk about the biopsychosocial spiritual continuum of the human experience. And there is a role in the artful use of medication in the right people. But the most important thing is treating the whole person and helping people develop adaptive skills to living their life, to trying to understand what pain and suffering they may be going through, and try to find some context to it. Again, your film just shows how all this can go very wrong.
You know, one thing I wanted to add in too, before I got into this part of the treatment world, I worked at the VA hospital for 13 years. And while we always thank veterans for their service, we don't take good care of them when they're coming home. And the treatment at the VA was pretty bad across the board. You know, most people were medicated, over-medicated, lots of guys shuffling along on heavy antipsychotics, misdiagnoses all over the place. And I actually had the experience of, there would be different psychiatrists going through my ward who literally didn't see patients. They just passed on diagnoses from charts and kept the medications going. And in terms of psychosocial intervention, there were some decent psychologists, but you know, you'd have a unit of 150 people. So there was no way to really do psychotherapy. So, you know, just in terms of the veteran experience, this rang very, very true.
Yeah, but I just want to add though, I know Dr. Pylko said, you know, this is bad mental health care, but our filmmakers are very clear to say that they picked diverse clients on purpose from different parts of the country, from different segments of society, to kind of show that this isn't really an isolated problem. It's pretty widespread. And just from my point of view, I had VA care, but I also had Department of Defense care, and then multiple civilian providers. So it wasn't just, I just happened to get a bad doctor. It was bad care anywhere I went, you know, just to clarify a little bit.
Well,
That might be part of the system. I believe if you had picked clients at the PCH system, you would not see that kind of care.
Right, you guys are good ones, obviously.
I
I'm
think
just
But
saying,
here's the problem.
part of the problem,
Most people can't afford our care.
right.
Yeah.
But I
Do it
think
right.
part of the problem too is 80% I read today of antidepressants are prescribed in primary care.
yes.
And they don't have knowledge of what these drugs are. And, you know, and 90% I think of all psych drugs are prescribed by non-psychiatric physicians. And so,
Yeah, you know who was responsible for that? It was Eli Lilly that developed Prozac. They were the first ones, this is true, that prior to that, antidepressants were very complicated medications. They were used sparingly because they had so many awful side effects that, you know, it was almost like taking poison at times, you know. But they had their place. Prozac came along with much fewer side effects, and they said, we don't need to have psychiatrists prescribe this. We can train primary cares to do this because it's easy. And it was a lot easier, but they weren't really adequate because it was so medically modeled that they never did any adequate evaluations. They don't have the time nor the training to do it. Occasionally, I've run into some primary cares who are really, really good. A very good friend of mine who's a family physician in Canada, because I trained in Canada, is remarkably good at treating people in his town just because there aren't any psychiatrists around, and does so much better than your average person and spends the time. But again, it's a different healthcare model in Canada than we have here.
Yes.
I have a question about why I'm hallucinating at your Zoom keeps going.
Adriana,
what drugs did you take, Jeff, before watching this?
Don't ask Jeff.
You come off the effects are too fast already.
But I think I think it is pervasive, because I do think it starts with just the training in terms of the medical model that has really taken over the training, even in, you know, psychology. I haven't been in school that long ago compared to, well, we're not going to date each other, right? But compared to Jeff or, Tim. So, and even then, I'm still learning about chemical imbalance and a dopamine theory in terms of schizophrenia. And so really the training that we are receiving, despite all the research, is somehow not saturating the educational system in which we are coming through. And so we come out and we are believing these fallacies that are clearly not being gathered and penetrating the textbook that we are learning. So
yeah, I taught abnormal psych for 30 years or whatever, and I used to teach about schizophrenia and the dopamine theory, which has been debunked, about genetic theories of twins separated at birth. Those have all been debunked because they weren't really separated at birth. There were tons of confounds in all these studies. And so all of the stuff we were teaching as kind of facts have been wrong. And the chemical imbalance one, and I worked with Dave Michalowicz, and, we were doing bipolar, and that was the basis of giving these mood stabilizers. And it's turned out there's no proof of the chemical imbalance theory. That in fact, the drugs cause them. Some of the psych drugs cause those.
Well, I think the problem is that, every time I hear the term chemical imbalance, I want to scream, because it's such a cartoon, gross oversimplification of very complex issues. And it's my pet peeve when things get overly simplified. The truth is the human condition is far more complicated than these cartoons. Again, I think even on the pharmacotherapy side of treatment, it's more of an art than a science, but they try to pretend it's a science.
mm-hmm.
You mentioned DSM. Tom Insel, who was the former head of the National Institute of Mental Health, when he was the head, he really took on the APA and there was a big controversy because he said DSM-5 or DSM, was it DSM-5?
It was 5, I think.
Yeah.
Yeah.
Said it was completely factitious book. It was more of a dictionary than anything else. And I guess we need our dictionaries to bill insurance, to talk to each other. But he wasn't going to at that time, he took the stance, he didn't want the NIMH to fund studies based on this dictionary, because these were kind of somewhat pseudo, they were more concepts than real things, but people treated them as real things.
Right, and these labels can be just so damaging, right, to individuals. And talking about just the human condition being so much more complex and trying to fit a medical model which works for medical conditions in terms of just our bodies to psychological processes, that's really so reductionistic. And that, I think, is a big part of the problem. In addition to just socially and culturally, where we are in a community, the United States, that I do believe that we have this cultural expectation that we should not have any negative feelings. And so that, I also think, fuels this desire to get something and get away with any internal distress and experiences that we are having, which is all a part of our human condition, as opposed to normalizing that and building up resilience to work through those experiences.
Which speaks to kind of how we treat people who are depressed, where, medicine sees it as a negative symptom to be gotten rid of and try to sort of numb it away. Whereas we see it as human experience that needs to be worked through. It's normal human experience to feel depressed when you suffer loss. And that you're actually short-circuiting it when you give somebody an antidepressant at times, because it numbs them and it can reduce the motivation to be able to work it through. Now, Tim and I have talked about this quite a bit in terms of when they are useful, is someone can't get into therapy, for example, because they can't get out of bed. Any of these meds we find useful to enhance the relationship, the therapeutic relationship. And that's the best use, where, we don't believe in giving those medications alone without that relational aspect.
That's so interesting. I remember a client here just recently, very afraid of freaking out. So I'm going up to the 3rd floor and she's like, well, what if I freak out? And I said, freak out. She's like, what do you mean freak out? I said, yes, freak out. So again, this fear of somehow our internal experiences. I did notice, I think Leslie mentioned in the chat, just right, about the medical model and whether that model even works for the, the body, given the connection. Absolutely, right? There's a lot of research out there showing that the relationship with your medical doctor actually impacts your health outcomes, even in medical procedures. So absolutely.
Well, which speaks to one of my other pet peeves is the term placebo.
Yeah.
And, the research does show, antidepressants are no more effective than placebo, and they're often then taken as that it's nothing. The placebo is nothing. It's sort of inert and it's nothing. And I think of it as the expectancy effect. So the expectation that someone's trying to help you and giving you something to help you actually allows your mind to start healing itself. And so, well, it'd be great if we come up with a different term for that, as opposed to something that suggests that it's sort of like nothing.
Well, I would disagree with you. The data shows in the right kind of patient, antidepressants are better than placebo. But there is the placebo component that can be optimized, which I think comes through the doctor-patient relationship, which I think is very critical. I mean, as I've said, when Adriana quotes me, a good relationship is a mood stabilizer.
Mm-hmm.
And I think understanding the psychodynamics, the role of medications, understanding in the right kind of patient, it may actually enhance recovery. But we have to understand, a lot of things get approved based on showing a statistical improvement as compared to placebos, but the placebos are working too. But more importantly is the effect size. And some of these medications are approved based that they can separate statistically, but their effect size is really small.
Yeah, for example, like a Hamilton
how much it
scale,
really is helping.
Yeah, I think depression, the studies that are touted as being more effective than placebo are usually 2 or 3 points on the Hamilton scale, which is
right.
statistically significant, but clinically insignificant.
Yes.
Yeah.
Yes.
But again, you're talking about averages, so that in those averages, there are individuals who get quite a robust response. But it's not, but you have to understand it's not the majority of people. But that has led this lie that primary care physicians are handing out antidepressants left, right, and center. And these pharmaceutical companies are targeting primary cares because they're low-hanging fruit.
Yeah.
And many psychiatrists are handing them out that way as well as benzos and many of these drugs. I mean, none of ours at PCH.
Let me read a comment coming in. One person says, I think among non-medical mental health professionals, there is a lot of embrace of pharmaceutical interventions because it has the allure of science, of research, best practices, and gold standards. I think it has the allure of being more intellectual and scientific, but with tragic results. I have felt like a salmon my entire career as a clinical psychologist in outpatient practice. It's exhausting. So he's making a point about, that it's kind of like like what David Cohen said in the film from UCLA. He said a lot of the research is presented as science, but it's really marketing.
Mm-hmm.
That's very true. And I remember when I was taking the licensing exam many years ago, before Adriana did.
Mm-hmm. Probably before I was born.
Long before that. They would actually, this is like psychological licensing exam, if they gave you a case with depression, they would fail you if you didn't mention you would refer to a psychiatrist for consultation.
Well, I mean, just to give you an example of what's happened in the field, largely due to, now we're talking about pain and the opioid epidemic. Because of a lot of lobbying by Purdue Pharmaceuticals, who made OxyContin, with various regulatory agencies, including JCO, they kept building the argument that if you weren't treating pain, you were not doing a good job. In fact, you would not get JCO approval as a hospital unless you could demonstrate on average patients left the hospital with less pain. That encouraged a lot more opioid treatment. They sold the argument that that pain is undertreated, and it got to the point where the California, not the California the Medical Board of California, maybe 10 years ago, required physicians to take a class and be certified that they would know how to not undertreat pain and ultimately overprescribe opioids. Now 10 years later, they're telling us we've all overprescribed and you could lose your license if so it's the kind of mixed messages. But Purdue Pharmacy made a huge contribution to that switch from, it used to be the idea that pain was part of healing and it was good to have pain.
Right.
And Purdue said, no, you're causing suffering. People should not suffer. We have these golden medications that can take away suffering. Instead, in the long run, they made people sick.
And I think that's part of the huge problem, Tim, right? Is that there's a difference between pain and suffering. And that somehow we have gotten the idea that pain is bad. And actually, pain helps you to understand the boundaries, even with medical conditions, right? If you have a sprained ankle, you typically don't want to medicate that too much because you need to be able to make sure it heals, et cetera, in terms of understanding your limits. But somehow we got the idea that pain is bad. And so really the goal here at PCH is that to have a different relationship with pain, that no, pain is a part of the process and that there is purpose in that pain. And how do you lean into that? How do you understand what's happening here? And then to have a different kind of relationship with that, because we believe that the suffering really comes from all of the strategies and skills and avoidance and behaviors that we try to then implement in order to not have pain. That's where the suffering comes from.
Because what this does is create a culture of avoidance.
Exactly.
And there's an optimal amount of pain to promote growth. You don't want too much pain. You don't want no pain. You want an optimal amount.
Right. Agreed.
I think I want to add, just from like a patient's perspective, that that there's a reinforcement that comes when you take a medication every day. Do you know what I'm saying? That there's this patient role, this sick role, this, when you get a diagnosis and you're given prescriptions for it and you spend an inordinate amount of time going to therapists, telling people what's wrong with you, it's not really good for us. I'll just say, from my point of view, for a long period of time, So I would like to shift the conversation because there's questions about this in the, and it's a CE point that we'd like to hit. Can we talk about informed consent? What does that look like, both from just being a therapy client and from being a client taking psychiatric drugs? What does that look like? What can we do to improve health literacy?
And my impression is that there really isn't much informed consent with prescribing most of the time that I've seen. They're not talking about withdrawal effects. In fact, and I've bantered with many psychiatrists on Twitter about this. When someone is having withdrawal, they'll often label it as relapse and say they need to go back on the antidepressant. And so, I think there's a lack of knowledge of what the research really says, so it's not conveyed to the clients. And I think there's an active not wanting to know to a certain extent.
What about informed consent for psychological treatment? Do we talk about the potential negative outcomes that can come out of psychological treatment?
Well, we talk typically when we're having clients come in, we're talking about the fact that they're going to be likely unpleasant experiences that are going to be brought up, and that that's part of this process. And the goal hopefully is to be able to help them lean into it and to gain skills to be able to manage and deal with that differently. And that sometimes someone may not be at that place where they can manage that, so yes, that's a part of the process of the treatment world, is to go through, that process.
When I was in training, they actually had a form we would give people that was an informed consent form for psychotherapy. In my practice, I would do it more verbally and sort of seeing what people's expectations were.
Or discuss the different treatment options, right? For example, like exposures. This is what you're going to be doing at exposures. You're going to be facing the very things that creates all of the anxiety or disgust. So really preparing for clients for what they're getting into so that they can make an informed consent. And some people, I've had clients who then say, oh yeah, I'm just not ready to do that. I'm not ready to come into treatment. And that's good, because willingness to participate is a good predictor of outcome.
I mean, just like we're talking about bad medication treatment in mental health care, we've also seen bad psychotherapy treatment. And it's a nightmare when, for me, when I get a referral to see someone to evaluate them for medication, and then I come to learn that the therapist that they were seeing all along is awful. They regress them, they make them worse.
We've had the experience when people refer to us. We've had therapists refer a case to us, or they were the previous therapist. And we always try and get people back to their therapist because we don't want people to feel we're stealing their client.
Right.
There have been times where we feel we can't, even if that person them bad mouthing us in the community, and
right,
we just feel it's too damaging.
Sometimes clients will verbalize the fact that the therapists at PCH are just absolutely, top notch, and are just able to form that kind of relationship with their clients, and just help them gain the courage to look at what's coming up together in a safe way. And so many times clients will not want to go back to their previous providers and want to stay with a PCH therapist. So to your point, Tim, yes, we have had clients from all over the country basically not wanting to return to their providers in hopes of staying with somebody, the person that they built that trust for the first time, right? They've been in therapy 5, sometimes 20 years, and they come here and in 1 month, they're like, whoa, this is a very different experience for them.
Right. But getting back to medication consent, I mean, you got to really talk about, everything is about risk versus benefits, cost benefit analysis. Again, I really believe strongly that good psychiatric care is more of an art than a science, and it has to be embedded in a good psychodynamic understanding of your client, and being able to form a really good relationship with them. And I've had many cases where the decision was, no, we're going to hold off. We're not going to go with medications right now. And others where they're in such desperate shape, you've got to do something.
Before shifting to the next set of questions, I just want to add something about informed consent. Also, I'm trained as a social worker, but I'm also on both sides of the fence. So, okay. So one thing, just as a patient, you're told to read those pamphlets.
Angie, all of us are on both sides of the fence.
I hope so. Otherwise, I can't get along with you.
Okay.
Anyway, okay, so they tell you to read the pamphlet. Okay, so when I read that pamphlet and it says dizziness, I'm like, okay, I might be a little lightheaded, no big deal. But coming through withdrawal, it's like a dizziness you cannot explain. So I want to say that those pamphlets can underestimate the true effects. Also, the pamphlets are created after 4 to 8 to 12 weeks study. It doesn't tell you what's going to happen 12 years down the line. And then the last thing I wanted to talk about was, wait, I'm almost losing it. Oh, just that we don't know what's going to happen. So how can you really give true informed consent if you don't know what's going to happen, because patients are on combinations, they age, things change. So is it really something that we can ever attain truly?
Well, I've been doing this for 35 years in private practice. And at the end of the day, some people there are many people who have no problems whatsoever going on off medications. There are some people that have exquisite sensitivity, and common things being common, and do you point out every uncommon thing? It's hard. But what I mean, there are just so many different factors, constitutional factors, and if you again, it all has to come out in the relationship. I have many people come to me begging me for something, and I'm not sure they need it, but they beg, and they have no other resources for help. So you do what you can, and you try to do it with compassion and and caring. You have to look at each person you see it like they're part of your family. What would you do if it was your sister or your brother?
Like that.
And informed consent has to come, or good psychoeducation about treatment has to come from that kind of way of relating to your clients.
Right. I like that. So let's shift a little bit to someone's talking about, the insurance company reimbursement, their role in our current system. And then we have another comment about, let's see, it goes up a little bit. Okay, about psychiatrists that are no longer trained in using talk therapy and rely exclusively on medication. What are your thoughts about this?
Yeah, let me talk about the insurance and also throw in pharmaceutical companies. Their business model is to make as big profits as they can. It's not about caring about patient care, insurance companies as well. And so, I think one of the problems, and it's a problem with a lot of treatment out there, when people put their business model in front of their clinical model, you get bad treatment much of the time. And so I think that's the basic business model of pharmaceuticals and insurance companies, is to make as big a profit as they can. If you can just give someone medication and not, long-term psychotherapy, they see it as advantageous. When I used to do private practice and would take insurance, I stopped after a while because I'd be arguing with these people at the insurance company where they give me 6 sessions for someone who had a severe bipolar disorder.
Right. Yep.
Yeah.
And they're ready to deny claims when the person sitting on the other end, we've had this a lot with utilization reviews for our clients, where somebody on the other end is thinking, oh, they need to be on a medication, even when the client is saying, I don't want to be on medication. Therapy is working for me, but somehow it's not working and the gains are not as fast as the insurance company would like to see. And so they're like, okay, so what's the plan for medication? And if the client doesn't agree to be on medication, then claims are denied. So it really feels like a trapped system that somehow the insurance company is in bed with the pharmaceutical company.
Yeah, I've certainly had situations. I do hospital work as well. Someone comes in, maybe they're in a psychotic depression, they're profoundly ill, suicidal thoughts, and I'll get a call from the utilization review nurse telling me, well, the insurance company, you haven't changed the medication regimen for the past couple of days. If you don't, they probably won't cover any more days. I said, but that's absurd. That there's nothing that makes sense out of that. They need to be in the hospital for their safety, because they're gravely disabled or they're a danger to themselves. Medications, to the extent they help, they don't happen overnight. That makes no. It's just a fallacy. Even if you follow, even if you don't believe that placebo-controlled trials in antidepressants, typically separation from placebo in those studies occurs maybe week 3 or 4. So it's always interesting when someone comes from the hospital and they get better in the first week. It can't be the medications. It's the containment. It's the relationship.
And in therapy, we call it a flight into health.
Well, I think people, when they're going down from the count, they need to be rescued and contained. And I think it's not the medications. There may be bad. I'm not saying not to give medications, but when you have insurance companies deciding how many days they'll cover based on whether you're going to raise the medication or change it, that's crazy absurd.
I remember when I was at the VA and I used to do, with a psychiatrist friend, we used to do a little, like a workshop with some of the residents and interns. And they were talking about antidepressants. And the residents were saying, well, since it can take 3 to 4 weeks for antidepressant to work, if someone's really suicidal, can we use ECT? And I said, you can talk to people and help them contain. And they looked at me like I was speaking another language.
Wow.
And I think that speaks to, I forget whose question it was, about psychiatry training in more recent years, where it's become just psychopharmacology and therapy training.
Let me give you an anecdote from about 10 years ago. I got a call from a mother who got my name from National Alliance for Mental Illness. Her son, who had schizophrenia, was at UCLA. He was in and out of restraints. He was physically attacking people. And she was getting very frustrated. He wasn't getting better at UCLA. And would I be willing to take him? And I said, okay. sure, if you can arrange a transfer. So I get a call from the resident to give me the clinical information for the transfer. And she says, "You sure you want to take this guy?" And I said, "Okay, I mean, sure, why not?" And I asked her, "So what do you talk with him when you sit down with him?" And she says, "Well, what do you mean?" I said, "Well, what do you talk about?" And she said, "Well, he has schizophrenia. You don't talk to him. He's dangerous."
Oh.
So finally he's in the hospital, meet him the first time. He's out in the yard. I have my iPad with me and I asked him, so what do you like to do? And he actually was a budding filmmaker, and he made some music videos with these different rock bands. So I said, well, let's look it up on YouTube and watch it together. And so we started talking about all that. He never was violent. He never needed any intervention. He was discharged in a week, doing much better. I didn't change his medications. I talked to him.
Right. Tim,
They weren't talking to him at UCLA.
Yeah.
I trained there. So I was very disappointed.
that is very disappointing. Hello, as a former Bruin, very disappointing. But that is also somehow transferring to the classroom for master's level clinicians in training as well, because I actually was just having this conversation with our practicum student at Pasadena, and she talked about even in her practicum supervision this week, where one of the, or actually even her supervisor in the class and some of the classmates could not understand what kind of work she could be doing with the population that we were servicing at PCH Pasadena, in terms of like, what do you do? You know, you got to wait till they're medicated in order to do therapy with people who are experiencing hearing voices. So that again, this culture of whatever we don't understand, somehow we want to push away, as opposed to let's engage with it. Let's learn more. Let's lean into it. So this is not just in terms of psychiatry and moving away from, you know, this kind of training, but somehow this is also within, you know, our system as psychologists and master's level clinicians.
Awesome.
I definitely had that same experience. I just graduated 2 years ago, and it was very much like social justice is for everybody else except for those people with serious mental illness. And one of my favorite quotes from Robert Whitaker in the film, he said this a long time ago, but it was, when we don't understand people, we hurt them.
Yes.
Just don't understand, you know, and they deserve that too.
Well, it's our job to understand.
Yeah.
To
That's
try to understand.
I remember seeing, and Tim, you may know of him, Bert Karam, who was
I know
down
him.
in Chicago. He was a psychologist who was expert in schizophrenia, and I heard him speak. It was a long time ago. And he said that schizophrenics were kind of in touch with the primordial part of human experience, and that we medicate them to kind of quiet them because it makes the provider feel very uncomfortable.
Yeah.
And he was like, you know, you can talk to these people, and you know, you might need some medication to make them able to sit and talk with you. But it shouldn't be long-term, and it shouldn't be over-medicated.
I mean, I have a lot of clients who hear voices, and as long as they're comfortable with them, and you know, we have great talks about what their voices are telling them.
Yeah.
You know, I had one client who told me, please don't give me medications, get rid of my voices, because I have very nice voices. They keep telling me I'm a nice person and that people will like me and I'll do well in life. And it's like my own private cheering section. I said, great, we're not touching them.
Well, you did open dialogue before open dialogue. So.
Perfect. All right. Well, we're running out of time, so I want to give each of you an opportunity to like offer some closing thoughts. Anything you want to say before we close each one? We'll save Dr. Ball to last.
Well, I can go. I think one of the things for me that struck me from one of our clients who, she was here a few years ago, actually, and she wrote this poem in the creative writing class, and it speaks so well about the philosophy of PCH and what she wrote in terms of leaving here being diagnosed. I think is just perfect in terms of the philosophy of PCH. She says, well, I have to put on my glasses for that, sorry. She says, I will go as far as to say, as people leave for the last time California's sun, They will leave diagnosed, relentlessly resilient, stubbornly hopeful, brilliantly brave, courageously tenacious, and a warrior, always a warrior. And that is our philosophy at PCH, not for you to leave here with a mental health diagnosis, but to leave diagnosed as a warrior.
Dr. Pylko.
Well, again, I really appreciate your film. I just want to say, this is an example of what not to do. There is good mental health care out there. This is not an example of good mental health care. Again, as I said, medications are not good or bad. They're just as good as the treatment environment and the clinician prescribing them. They do have a role in mental health care, but they are not the center of mental health care. And I think having an integration in treating the whole person and not trying to oversimplify and medicalize things are just is just the only way to get any adequate care. And we can see from this film what kind of damage it's done to people to do it the other way.
Dr. Ball.
You know, and I know, I do think, Tim, you're a bit of a unicorn. I don't think it's, I don't think it's as common in modern day psychiatry. I mean, I feel like the mental health system is very broken. And that part of that is, the training is all about psychopharmacology. There's very little psychotherapy training in psychiatry anymore, at least at UCLA and on this coast. I think a little bit more in New York, I've heard, but I don't think that much more. And so, you know, and I think I also agree with the biopsychosocial model, and many psychiatrists will say they follow it. I can count on one hand in 30 plus years of private practice when clients were referred to a psychiatrist the times they called me. You know, now I didn't work with Tim because you would have called me, but you know, these were people I'd seen for years, and they didn't take it on themselves to call and get any information. They just medicated. And so I think we have a really broken system, like so many of our systems. I think that kind of greed and power have taken control of a lot of our fields. And, you know, that's what we're sort of trying to battle against.
I mean, you know, as I said, you know, the problem is there's a real lack of resource, but the problem is there's so much waste going to the wrong kind of care. If you could recapture that money and put it in the right kind of care, we'd have a lot more people treated well.
Well, and I think really paying more attention to context. You know, I think there's a study I always like to cite with all the, you know, millions and billions studying the brain and suicide and everything. There was a study, epidemiological study, that showed that if you, there's over 20, I think it was 20 years, it was a couple of years ago it came out. If you raise the minimum wage by $1, suicide rates go down 5%. And if you raise it $2, it goes down 7 to 10%. And so, you know, here's an example of something that's pretty much, you know, that it has to be cultural and social change that's going to answer, you know, why people are so depressed and so suicidal. I think the whole wealth disparity is a big piece of that. And so, you know, I think our resources need to be focused in other places.
Oh, but these things are even more complicated. You know, Denmark has often been listed as, on average, one of the happiest countries in the world. On happiest ratings, they rate higher than most people as a population. They also have one of the highest suicide rates in the world. So how do you figure that? Maybe if you're truly depressed around a lot of happy people, it really sucks.
Context.
Okay.
That's right. But Sweden, it's all those Bergman films, you know?
Yeah, I know.
There's lots of reasons not to want to be around in the world we live in today, you know?
Agreed.
That's a hard place to be. Well, I just want to say thank you for hosting this, Dr. Ball, all of you, for all your work that you're doing. I love that. It made me tear up what you read, because it's truly like, you know, show the human spirit. Like, this is a strong, resilient thing, and we can get through a lot if we just have the right support. So thank you so much for reading that. Thank you for being here in the audience. Thank you, PCH, for all the work you do. I'll just say a couple film things to wrap it up. The film will be widely distributed on public television in January 2020. We have a 3-year run with PBS, which is really exciting. We also have a Facebook, Instagram, YouTube channel. You can follow us on all the major news, all the major social media places. If you know any other organization or anybody else that'd like to host a screening, just get in contact with us. Our website is medicatingnormal.com. And that's really it. Thank you all for being here. Thank you. All right. Have a wonderful
Thanks a lot.
night.